All right, everyone, welcome. I'm really glad you could join me for this comprehensive review on the core principles of cardiac anesthesia. We're going to walk through the entire perioperative journey, really from the moment we first meet the patient in pre-op all the way through the complexities of the ICU. We'll use this session to hit the key decision points and the evidence-based practices that really define what we do every day. So here's our game plan for today. We're going to follow the patient's path chronologically, which just makes the most sense. We'll start with a preoperative assessment, then dive into the delicate dance of induction. From there, we'll tackle the beast that is cardiopulmonary bypass, navigate that critical weaning phase, and finally, wrap up with the vigilance we all need in postoperative management.
Okay, first things first. We're starting with what is, you could argue, the most important step of all, the preoperative evaluation. This is so much more than just ticking boxes on a form. This is where we build a detailed, patient-specific risk profile that's going to inform every single decision we make from here on out. A good outcome really begins right here.
Now, what's really fascinating here is seeing how far our risk analysis has come. We all know the classic red flags, right? Advanced age, a tricky reduced sternotomy, poor LV function. These are things we look for every day. But here's where it gets really interesting, the whole new world of perioperative genomics. We're starting to move beyond these broad categories and get down to a patient's individual genetic makeup. We can actually identify specific gene variants related to inflammation, like those for CRP or IL-6, or blood pressure, like the ACE gene. Think about it. You could have a patient who is genetically wired to have a massive inflammatory response to the bypass circuit, putting them at a much higher risk for vasoplegia or organ dysfunction. This isn't science fiction anymore. It's the future of a truly personalized risk assessment.
So, knowing the patient's risk profile is one thing, but seeing their physiology in real time? That's the other half of the battle. The cardiac OR is just an ocean of data, and every single monitor is giving us a vital piece of the puzzle. So let's just do a quick run-through of the standard of care.
This table lays it all out so well. Of course, you have your workhorses, the A-line, the central line, and the PA catheter for those really high-risk cases. And TE has become an absolute game changer. It's our window into the heart, letting us see function, filling, and those dangerous aortic plaques that could cause a stroke. That blind spot, by the way, is just simple physics. The trachea is full of air, and it sits right between our probe and the aorta, blocking the view. But the real shift, the thing I want to emphasize, is that we've moved beyond just monitoring the heart. We are now focused on end organ protection. Cerebral oximetry lets us see brain oxygenation directly, so we can act before damage occurs. And sure, BIS can be a bit tricky with hypothermia throwing it off, but it's another valuable piece of data. This comprehensive approach is how we prevent those silent, devastating injuries.
Okay, let's move on to induction. This is a period of controlled transition, but let's be honest, it's one of the most dangerous times for our patients. Our whole job here is to get them safely to sleep and intubated while keeping their hemodynamics absolutely rock solid.
This is the classic challenge, isn't it? We've all been there. One minute the pressure is in the tank, and the next it's through the roof. So what are those opposing forces that are always at play, and more importantly, how do we get ahead of them?
It all comes down to a proactive balancing act. On one side, every single drug we give is going to vasodilate and blunt their sympathetic tone. That means hypotension is almost a given, and it's especially dangerous in a patient with a weak heart that can't compensate. But on the other side, you've got this massive sympathetic surge just waiting to happen from anxiety and the stimulus of laryngoscopy. So our strategy has to be ready for both. We anticipate the drop by titrating our drugs slowly and having phenylephrine literally in our hand ready to go. At the same time, we blunt that hypertensive spike with good premedication and a deep enough anesthetic plane before we even pick up the laryngoscope with drugs like nitroprusside and esmolol right there on the cart. It is a constant, second-by-second adjustment.
And now we enter the heart of the operation, cardiopulmonary bypass. It's a truly remarkable technology, but it's also a profoundly unnatural state. We're literally suspending normal physiology. Our job completely shifts to managing this artificial circuit and doing everything we can to protect the patient's homeostasis.
The very instant a patient's blood touches the foreign surface of that bypass circuit, this incredibly complex hematologic cascade kicks off. Honestly, managing this is one of our biggest challenges during bypass. So let's break down exactly what's going on.
Look at this, it's a complete paradox. The circuit itself activates the intrinsic pathway. The surgical wound activates the extrinsic pathway. Platelets are getting chewed up and activated. Everything is screaming, form a clot.
But at the exact same time that contact activation is also turning on fibrinolysis, which is screaming, break down clots and bleed. So we're dealing with this bizarre state that is both prothrombotic and pro-bleeding simultaneously. This is exactly why our heparin management and our ACT monitoring have to be absolutely perfect.
Now, managing this delicate balance comes with its own set of problems. The very drugs we rely on, heparin to prevent clots and protamine to reverse it, carry their own significant and sometimes life-threatening risks. Let's dig into those.
First, let's talk about the one we all fear, heparin-induced thrombocytopenia, or HIT. This is such a dangerous and frankly counterintuitive condition. It's an immune reaction where the drug you're giving to prevent clots is causing the body to form antibodies that trigger massive platelet activation. The result is widespread, life-threatening clotting, even while you watch the platelet count plummet. Spotting this is absolutely critical.
This table really shows the full spectrum of what we have to be ready for. With heparin, besides HIT, you've got things like heparin resistance, which usually means the patient is antithrombin deficient. Then with protamine, we group the reactions by severity. Type 1, that's simple hypotension from giving it too fast. We see that all the time. It's easy to manage. Type 2 is a true allergic reaction. But type 3, that's the one that gives you nightmares. It's a catastrophic pulmonary reaction where these heparin-protamine complexes clog the pulmonary vasculature. You get an immediate spike in PA pressures, acute RV failure, and total cardiovascular collapse. That is an emergency that means you're going right back on bypass. Understanding these reactions isn't just academic, it's about being prepared to save a life.
All right, let's move on to one of the most critical, high-stakes moments of the entire case. Weaning from cardiopulmonary bypass. This is the moment of truth, where we ask the heart and lungs to take over again. Success here isn't about luck. It's about having a systematic, checklist-driven approach every single time.
To keep our heads straight during this really high-pressure moment, a good cognitive aid is a lifesaver. A simple mnemonic can make sure that we don't miss a single critical step before we make that move to come off the pump.
You know, a mnemonic like CVP is just so incredibly powerful in these situations. It helps us turn potential chaos into a controlled, repeatable process. Under C, we're running down the list: patient's temperature, their rhythm, their contractility on TEE. One of the biggest ones here is cells. Do we have enough hemoglobin on board? For V, it's all about getting the lungs working again with ventilation, using our TEE for visualization to hunt for any trapped air, and having volume ready to go. And for P, this is all about preparation. We know the predictors of a tough wean, we have our pressors and our pacer ready, and we've corrected our labs like potassium. Following this checklist religiously is what makes for a smooth, uneventful wean.
And if that first try doesn't work, we don't panic. We have a clear, logical escalation plan. Step 1 is always optimize preload. Is the tank full? We can get volume right from the pump. If the filling pressures are good, but the heart still isn't squeezing well, then we move to step 2, enhance contractility with inotropes like epinephrine or milrinone. And only if that's not enough do we escalate to step 3, which is considering mechanical support like a balloon pump or making that tough call to go back on bypass to give the heart a rest.
Okay, so we're off bypass. The case isn't over, not by a long shot. Successfully coming off the pump just means we're starting the next critical phase. The immediate post-op period demands our absolute vigilance for a whole host of complications that can pop up as the patient's body tries to get back to normal.
Our job now really shifts from that second-by-second crisis management to surveillance and optimization. So let's go over the big-ticket complications that we need to be watching for in those first few hours and days and talk about the cornerstones of managing them.
This slide just drives home the point that our job is far from done after bypass. We really switch hats from being just a cardiac anesthesiologist to being a full-on intensivist. We're managing a massive systemic inflammatory response. We're on high alert for low cardiac output syndrome, tweaking every variable we can. We're managing the ongoing risks of bleeding, stroke, and AKI. We're not just protecting the heart anymore. We're protecting the brain, the kidneys, and the patient's entire system as it recovers.
This is the million-dollar question at 2 in the morning in the ICU, isn't it? The chest tubes are pouring out blood. Is this a surgical problem that needs a trip back to the OR, or is it a medical coagulopathy that we need to fix with blood products?
So here's the bottom line. You have to use your eyes and the lab data together. A surgical bleed is usually bright red, fast, and it clots in the tube. A medical bleed is a slow, generalized ooze from everywhere, and it just doesn't clot. But the most important tell is this. If you are throwing products at the patient, platelets, FFP, cryo, and your lab numbers are actually getting better, but that chest tube output is still cranking, you have your answer. No amount of FFP is going to fix a bleeding vessel. It's time to call the surgeon, because that patient needs to go back.
And in the end, after we've gone through all the complex physiology, all the pharmacology, and all the potential disasters, it really comes back to this one simple truth. Cardiac anesthesia is a team sport. The communication between the surgeon, the perfusionist, and us is constant, and it's absolutely critical. This quote is the perfect reminder that sometimes the most important intervention we can perform is just clear, calm, and respectful communication. Thank you so much for your time today.